joining us today for the 9th of our Columbia CBIPS lecture series on the AEC experiences relating to COVID-19. I'm Rick Bell, Deputy Director of Columbia's Center for Buildings, Infrastructure, and Public Space, and Adjunct Associate Professor at Columbia's Fu Foundation School of Engineering and Applied Science. We just turn this over to those. These lectures bring together the people who will be addressing the impact, response, recovery, and preparedness of the architecture, engineering, and construction community to the coronavirus pandemic. But they are also linked to the relation of social, economic, and environmental justice to the new normal in the AEC community. Our first 7 speakers from New York, Los Angeles, Paris, and London all address the experiences of their offices in relation to COVID-19, impact, response, recovery, and preparedness. We've heard about public buildings, civic infrastructure, and changes in office operations. Today, we return to New York, where Health and Hospitals has reacted to the need for critical care and antibody testing during the pandemic. Subsequent talks will focus on the U.S. Army Corps of Engineers, civic infrastructure in the city of Sao Paulo, transportation infrastructure in the city of Chicago, and the practice of Mount McDonald. Please check our website to see more information about next speakers and co-moderators. I would also like to thank the organizations with whom we are collaborating in presenting these lectures. They are the American Council of Engineering Companies, New York, thanks Jay Simpson, the American Institute of Architects, New York, thanks Ben Prusky, the American Society of Civil Engineers, thanks Tom Smith, the Consortium for Sustainable Urbanization, thanks Lance Brown, the CMAA of New York, New Jersey, and thanks especially to Vinny Falkowski, who's with us today as co-moderator, and Engineering News Record, thanks John Tuckman, and the National Academy of Construction, thanks Wayne Crew. Today, I am pleased that Vincent Falkowski has joined me by Zoom to be co-moderator and respondent. Vinny is Deputy Commissioner of the Nassau County Department of Public Works. He previously served as an Executive Director at the New York City Department of Design and Construction. He is current President of the CMAA New York and New Jersey chapter, and a former colleague at DDC. Welcome, Vinny.
Thank you.
Our speaker today is Christine Flaherty, Senior Vice President at New York Health and Hospitals. She previously served as Deputy Commissioner of the New York City Department of Design and Construction and is the immediate past president of the CMAA New York and New Jersey chapter. Full bios are on the CBIPS website. Thank you for being here today with us, Christine, and I look forward to seeing your presentation. All yours.
Good afternoon. Thank you for attending this New York City Health and Hospitals COVID-19 impact on our system and where we are moving forward. This presentation is my first Zoom meeting since the pandemic, unlike probably many members of the audience. I'm just trying to move my slides. There we go. So this presentation does provide continuing education credits, both for CCMs and PDHs, and the learning objectives of this quick talk will include a description of New York City Health and Hospitals, as well as I will speak about our system-wide response to COVID-19 care at our acute care and long-term care facilities. I will look at the needs that arose during the pandemic and throughout as we look at the future and what we need to do to make our hospitals resilient and pandemic ready. And I'll talk a bit about what we've been doing standing up as an organization, T2, and the antibody and testing throughout the city of New York as part of the city's response to COVID-19. And so quickly, let me speak to the amazing organization of Health and Hospitals. We're the largest public healthcare system in the country. We serve over 1 million New Yorkers each year and provide them care through our 11 hospitals, our 6 FQHC diagnostic treatment centers, over 50 community health clinics throughout the boroughs. We also have 5 long-term care facilities, also called SNFs, skilled nursing facilities, and we do provide home care to our patients that are better served through care in their residential environment. And so we have a team that does that. In addition, we have our own health plan, Metro Plus, which supports and provides low-cost insurance, great insurance to many of our patients. And we provide care to all New Yorkers with no exceptions, regardless of status, regardless of their ability to pay. Our mission is to care for all New Yorkers, and it's an incredible mission. Since joining Health and Hospitals, it's been humbling to be part of an organization that really is in the forefront in caring for all. And I like to say to many, it's like we're the largest nonprofit around when I look at what we do every day to save lives. Our mission and vision and our strategic pillars is represented here, and equity, while not here in this visualization, is really a core value of our organization as we look to continually improve our outcomes of care, the experience our patients experience as they're receiving care in any number of our facilities. We have been working diligently and hard to move ourselves to a financially stable situation as an organization. And we really are focused also on patient and staff safety, as well as access to care in all 5 boroughs for all New Yorkers so that they can live their healthiest lives. Our values are here listed that gives you a sense of kind of how we organize ourselves, and really back to the main vision is ensuring that in all cases we're facilitating the most healthiest lives for our New York patients that come through our walls. So moving over to our system, the largest portion of our system, over 20 million square feet, is our 11 acute care hospitals. And this is a map that shows where our acute care hospitals really transposed with positive COVID cases. And this is data from DOH-MH's website that is updated daily. This was an update that occurred Monday. And so what this shows you is really the fact that our acute care hospitals were really in the epicenter of some of the hardest hit neighborhoods. And so we did have a large volume of suspected and COVID positive patients that we cared through starting in March all the way through today. Our caseload of inpatient patients has drastically reduced, and at peak we were in the thousands of patients that we were caring for concurrently across our system. So to give a sense to the large group of folks that are on this call, a sense of the office that I lead, it's the Office of Facilities Development. This is a system-wide office that supports all of those facilities. And the role that we play within supporting our clinical and operations leadership at those facilities, we have our amazing trade union work staff that's over 700 strong throughout our facilities, and directors of engineering that lead facility operations at all of our facilities. We have a department that leads planning, design, and construction, so any hiring of design consultants, contractors, construction managers. We have that function that facilitates that across the system. We have a team of budget and contract individuals that support kind of all of those functions, whether it's facility management, planning, design, and construction, and that's our technical support services team. And then we have a small office that is focused on our real estate and housing with an eye towards looking more strategically around our chronically homeless patient population and leveraging our assets to do that, recognizing that we currently have some existing affordable housing on our campuses, and we're looking at expanding that portfolio. I'm trying to change the slide. Bear with me. I'm having some technical slide changing challenges. Hold on. So as I'm trying to attempt to change the slide, just again, the purpose of our office, I think I covered the key things that we functionally do and our value system aligned with the organization. During the emergency activation, which commenced from a planning perspective actually as early as January, OSD really led the facility-focused element of the logistics arm of our incident command structure. So now I'm going to get into our facility response during the pandemic. There were 5 main areas of focus for our office. From January to February, we were really focused on a space inventory of our assets and our rooms, the physical characteristics of our rooms, as well as looking at planning for the potential to increase our bed capabilities throughout our hospital system. And so at that time, COVID-19 was seen as a respiratory-borne illness, and we were largely focused on our negative pressure environments, what we could do to consider enhancing the negative pressure environments, and making sure we had a full inventory of that, as well as looking at air quality standards and locations where we could look at adding capacity to our existing acute care facilities. We also focused largely on enhancing our ICU capabilities and increasing that, building new bed capacity through our systems. We were installing large quantities of outside structures that would further support queuing, testing, and other clinical needs as large volumes of patients were coming into our system. And we were supporting OEM as we looked at alternative care locations for low acuity patients to be taken care of as the hospitals became very full with COVID positive high acuity patients. So this slide shows a period of time and a number of things that were happening concurrently from March through June. And so now I'm going to kind of speak to the tremendous amount of work that our team was part of, working closely with both our in-house trades as well as a lot of private sector partners to accomplish what probably normally would have taken 24 months to 36 months within a very short period of time. In early March, along with the city, we activated our emergency status, allowing us to tap into emergency contracting capabilities and move on a number of various fronts. So very quickly, we were working with our ambulatory care partners and the hospitals and setting up our first testing tents for COVID. Testing was happening locally at our hospitals, and we were establishing outdoor locations for that with tents up so that we could make appointments using our systems and appropriately have patients come through those testing tents and get that volume outside of a traditional ER setting. And so we quickly were setting those up, and we branched that out to our Gotham locations as well. And over the period of many quick weeks, we had set up a large quantity of tents throughout our system. Concurrent to that, in mid-March, we started visiting anywhere we could find potential to activate low acuity care environments that would serve to further decant our hospitals. Back in January and February, we were already brainstorming with our CEOs of our hospitals what would happen when we were confronted with a surge, which units, where would we be doing rapid discharge, where would we be trying to activate inside of our walls of our hospitals for higher acuity surge beds to care for COVID positive patients, and what could we be doing as a system to provide low acuity care in other locations so that we could further decant our acute care hospitals to provide high acuity care in our COVID care. And in doing so, we started exploring surge locations, including units that hadn't been turned on for staff and patient care for some time. And so in March 13th on a Friday evening, we visited Kohler Hospital and identified a number of floors there that could be reactivated in an emergency basis to care for low acuity patients. And by Sunday afternoon, we had a kickoff meeting with contractors, colleagues from Housing Recovery Office, construction managers, and we identified 4 different floors of Kohler Hospital to essentially work 24/7 with North Star and a number of CMs helping us manage this and reactivate 350 beds so that we could have a temporary hospital stood up, Roosevelt Island Medical Center, in collaboration with DOH, the state, and within 10 days, the construction was complete, and within 7 more days, by the end of March, we actually had seen our first patient at the Roosevelt Island Medical Center. Concurrent to that, we also visited North Central Bronx, where we had unactivated floors that had been looked at for many reasons within health and hospitals, and we commenced another major project with a team to build ICU beds, temporary ICU beds, critical care beds at NCB, 120 beds in really record time. So these 2 major design and construction projects were launched. One was completed in March, and I'll go into kind of some of the details on what was achieved at NCB as well. Concurrent to that, we were looking at alternative sites in collaboration with OEM and City Hall, and it was identified that alternative sites for low acuity care could be achieved at both Billie Jean King and the Brooklyn Cruise Terminal. Department of Design and Construction jumped in to help OEM, and we facilitated kind of the clinical portion of this, ensuring that you have a clinical leadership structure to handle these additional sites that are off-site from our walls, from our campuses, which is kind of an interesting lesson learned for us. And so those 2 sites were built out in collaboration with DDC, who led the design and construction, and our side leading the clinical decision-making associated with standing up a low acuity hospital. And Billie Jean King was opened also in record time in April. As all of this was occurring inside the walls of our acute care hospitals, our trades had been busy opening up additional wards to our hospitals. We were busy deploying additional HEPA filtration, monitoring the oxygen systems, ensuring that they were running at all times, and they did run at all times, and addressing any new needs that were coming up. Dialysis was an example of an area that became a major challenge during COVID care, recognizing there was a large amount of renal failure concerns with COVID-positive patients, and we quickly deployed additional resources within our trade staff to make as many rooms dialysis capable as possible. And so these were many of the efforts that were happening during the height of COVID. I'm going to go to the next slide, which covers a number of the accomplishments that our system was able to achieve during a tremendously challenging set of months. So the main thing was our operations were maintained and we were able to care for all patients. That was a tremendously challenging 24/7 achievement that was a testament of the hard workers of our directors of engineering, our CEOs and COOs at the hospitals, and all of the trade staff to really react and create new spaces for our clinicians and our patients as we stood up a number of new units that were caring for COVID-positive patients. A testament to that is we actually started with a baseline of approximately a little over 300 ICU beds in our system, and we stood up over 1,000 ICU capable beds across our hospital system. We peaked at almost 1,000 patients concurrently receiving ventilator, high acuity care that were COVID positive, and we really were able to care for all of the patients that needed that care and transfer among our hospitals. One of the key strategies was we were able to transfer among our hospitals where if a hospital was getting incredibly full with COVID positive patients that needed high acuity care, every evening at 7 p.m. we were looking at where the transfers could go, and it's really a collaborative effort between our clinical leadership, our operations side, our physical space side, and our supply chain partners to see all of those elements to ensure that they were being addressed. We also worked feverishly to enhance our air quality wherever we could, where we had hot units that we were caring for, and enhancing that with HEPA filtration, negative pressure environments that were established temporarily, and enhancing the environment, recognizing that we were trying to ensure we were protecting patients and staff at all times. I spoke already about the dialysis beds and the quantity of additional dialysis capabilities that we stood up. And we also were increasing our O2 availability as we were continuing and watching the surge grow, not really knowing the one constant here is change you cannot anticipate with COVID-19. And so there were a number of areas of clinical care that were not being provided because we were focused on COVID, elective procedures, behavioral health. We were working closely with the state, and so some of our behavioral health units had been decanted during this. We actually, on another 24/7 construction project with Turner and North Star and Tishman, stood up bringing oxygen into behavioral health wings in order to have additional surge locations for COVID patients to be, and those were 24/7, 10 to 7 day projects that were completed in record time in order to free up more ICU capabilities at the critical high acuity level and provide lower acuity COVID care to patients in a setting that allowed them to be cared for and staffed. We brought over 470 new beds online that hadn't ever been providing care, and with that comes supplies and clinicians, which were brought in also in record time from a temporary staffing perspective, as well as I would say the federal government coming in with their staffing from the various military branches were a tremendous help to our system as well. So these are just some pictures of some of the surge work that was happening in our walls. To the left is a picture of our assistant DOE pointing at the ceiling and just pointing out how challenging it is to get that oxygen into one of our behavioral health wings of Elmhurst Hospital. And to the right is our temporary oxygen tank that was brought into Kings County Hospital, where we did additional low acuity beds that were brought online. The imagery here on this slide, the next slide, I'm trying to make sure it's moved on. So the next slide shows the North Central Bronx project, which are temporary critical care beds that were designed and constructed at the same time. Skanska was our main builder here. Northstar, our emergency contractor, came in to do abatement and demolition immediately. The project kicked off on the 19th, was the first time we met at the site, and immediately demolition and abatement commenced. By April 8th, you can see the workforce is getting in the MEPs. They were coordinating, they were drawing. Lothrop was our designer here with Siska doing tremendous work, as you can imagine, meeting every single day to coordinate work, to really get this project delivered pretty much as a integrated project beyond design build, very much an IPD type of project. We had amazing healthcare worker heroes doing this construction, 2 shifts of 12-hour shifts, and this provides 120 critical care beds that provide all the attributes you would have and need in an ICU. We had a phased completion here, so the first set of 20 beds were open April 28th and immediately saw ICU step down patients. And we now have 100 beds on the 15th and 16th floors of NCB ready to go, already seeing COVID positive patients today. North Central Bronx played a key critical role for us as a system in receiving a large number of stable COVID positive patients that could decant our other acute care hospitals as we worked to ensure that we had the 30% ICU capacity in order to reopen our services. And so this project has been a tremendous undertaking and a tremendous amount of hard work by many involved, and it's something to be incredibly proud of for that team to accomplish this tremendous millions of trades workers' hours were achieved on this project. So as we look to the future of where we are trying to go and what we learned out of the impact to COVID-19 to our system, we have had, starting in April and May, we started meeting with our CEOs of our hospitals to ensure that we are getting feedback on ensuring we can address their ongoing COVID care concerns. And there's some major areas that we're focused on. One, ensuring that we provide in the future flexible spaces that allow us to provide critical care to patients in the case of a surge, that we're looking long-term at our air quality through our hospitals. COVID-19 hit New York at a time where we were in the spring and we were able to easily adjust our systems, albeit manually, because we're not funded with sophisticated BMS systems and enough VFDs for controls in place, but looking at a lot of fresh air and a lot of negative air where possible. But as we look to the future, we need to enhance our air quality systems. We've had an assessment done, and there is a definite need for long-term investment in increasing our air exchanges and further enhancing our systems with both filtration, UV lighting, and having more controls on negative and positive pressure capabilities on many of our areas is a big area of focus for us that we've quantified to be approximately $500 million of need. And also we've been working diligently to enhance our capabilities for COVID care in our lower acuity observation areas, increasing our monitoring, working closely with clinical leadership and EITS for monitoring our patients that are not at high acuity, but have COVID, need to be checked to ensure that they don't get worse. And we want to make sure that we're checking their oxygen, looking at having advanced telemetry at our nurses station, and keeping an eye on them for observation with the hopes that they're able to be discharged successfully, but those areas need further visualization so that we can make sure we enhance their care. Dialysis and having the right amount and increasing our quantity of dialysis is an area that we're continuing to focus on and invest in, and looking at, unfortunately, there's a population of patients that struggle beyond a typical time frame in our ICUs and really are more, lend themselves more towards long-term acute care settings. We are, I think, the only certified hospital in the state. Carter is a long-term acute care hospital. We've been working closely to support that hospital, and we see that as an area that working closely with the state where long-term acute care hospitalization maybe require additional capacity in our area. And currently we are also working on looking at our role in the quarantine of a COVID positive patient. Our colleagues are running the hotel program, which essentially assists and support COVID positive patients that may need to quarantine away from their family and loved ones and may not have an appropriate setting in which to do so. And really in the long term, we're looking to build capacity for all care, both non-COVID patients and COVID patients. Today, the emergency does not allow us to look at FEMA Category E, but we need to advocate for healthcare infrastructure spending for our hospital system to ensure that we are pandemic ready and we can really support the level of care required, both for individuals that need to come to our ERs for a heart attack, as well as individuals that have COVID-like symptoms. And so we have been working closely at all of our hospitals to ensure that we have basically areas of our hospitals that are both appropriately providing for care for COVID patients and care for others that require that trauma 1 level care that we provide on a daily basis. We're also very focused on telemedicine, which grew tremendously during the height of the pandemic, and really leveraging that moving forward. And we're supporting the T2 initiative that is being really led by City Hall and H&H. So quickly on T2 testing, this has been a collaborative effort working closely with many city partners, as you can see by the slide. And so the spaces have been identified, and in record time, we have 27 sites operationalized thanks to the hard work of partners like DDC and SCA, and I can't remiss to say DOB, who's been a tremendous leader in this area. We've focused on the operations of this from our office's perspective and providing clinical guidance in collaboration with Dr. Long, who leads T2. And we are doing 12,000 tests a day. That was 2 days ago. I'm sure the number's increasing daily, really with the focus on ensuring that we're doing everything we can to mitigate any future surge. This is a sample of one of the first sites that were open, the Highgate testing site, which provides a tremendous amount of space available for individuals to have walk-in testing during the hours of operation and allow them to get test results quickly, and the tracers are following up with them and working to address any needs for the COVID positive patients. So I spoke already a bit about the long-term impacts for COVID-19. We really do want to engage in a meaningful long-term discussion, ensuring that we are pandemic ready, ensuring that we as a local system are working closely on level loading our system as well as those of our colleagues and other health systems throughout New York City, and that we are advocating as well for really healthcare infrastructure spending, because that is definitely needed as we look to the future for health and hospitals and New York City to get ourselves, back to some semblance of economic growth and safe economic growth as we look to move forward. So these are some of the things we're focused on. Some other lessons learned for us as we fought the pandemic during the surge was you really had to have the trifecta of the space ready to go, the staff, as well as the supplies. Those three things had to be in place in order to appropriately care for patients during a surge. And that close alignment was really critical, and it was like an orchestra. We had to work so closely together, constantly communicating to ensure that we were moving in the same direction. And with that, I'm ready to take questions and comments from the audience.
Vinny, would you like to ask the first question?
Sure. I'm going to be selfish and ask my question, if that's okay. Christine, what was the biggest challenge in procurement, specifically system components needed to increase capacity?
I think that I'm going to not focus on PPE because that would be my colleague. I mean, clearly, I think it's been clear that PPE is a challenge, but from a standpoint of systems, I would say for us, HEPA filtration is definitely still an area of sourcing that can be a challenge, especially now with the increases throughout the nation. I think air quality is a big focus, and in tandem with that will be basically HVAC systems, whether we're talking about air handling units, et cetera. But I think the MERV filters and those types of air quality enhancements are definitely one of the areas that I would say would be Achilles heel.
Thanks, Christine.
I'm going to do the same, Christine, and ask a question that we've had as a kind of a template question for each of our speakers, which has to do with designing or anticipating a new normal and working toward codes and standards that perhaps haven't been fully written in response to what the pandemic has brought. You mentioned the need for significant investment, $500 million to enhance filtration, ventilation, and disinfectant lighting. Could you just talk about how you work around the potential lack of resources, yet great demands for change systems in all these facilities?
Yeah, I mean, I think it's really the biggest challenge we face, frankly, is that before COVID hit, our system was already challenged with $1.5 billion of needs that were unfunded from an infrastructure perspective. And we've been fortunate to be working with OMB to support, an amount of capital funding, but not able to address everything. And we were already forced to prioritize within really state of good repair type of work, not even that many exciting, new buildings or anything like that. And so I think as we look at the new norm around space and social distancing and physical barriers, I didn't mention that, but right now we're definitely today installing a number of physical barriers throughout our sites. I think that we need to also be as creative as we can on operations to try to reduce the costs associated with kind of reconfigurations in certain types of spaces. So from a standpoint of like our office space, we're really thinking about, telecommuting, staggering schedules, sitting from, every other person, rescheduling how we sit in lieu of doing major modifications so that we can focus our major modifications in areas that really have to be addressed. And those are the areas that include, types of clinical procedures that really clearly create an environment where we really have to very carefully reconfigure our spaces. So those include our ERs, our dentistry, our labor and delivery, some critical areas that we really are going to have to do reconfigurations to ensure that we have both patient and staff care at the forefront. Because without those reconfigurations, we're going to be running certain types of practices without regular capacity, because it's just impossible with the current physical constraints we're faced with.
Good answer. Vinny, do you want to turn to questions from the audience members?
Sure. Let's go with the first question. And Yanis, I apologize if I don't get your last name correct. Tisselgakis. His question was, what is the breakdown of hospital costs between labor, administration, facilities, professional staff, and materials? And if you can answer that, is there a place to find the cost data?
So, to be honest, it's hard for me to process the question because I'm not sure if they're speaking about construction labor or clinical labor.
No, let's stick
And
to construction, Christine, because it's a construction and facilities discussion.
So I don't think we don't have that info compiled in a way that would be able to, I don't have a breakdown of that. Unfortunately, we don't have a controls team within health and hospitals. And as we speak today, we have a large quantity of invoices that we are in the midst of processing. And so I don't think we're at the point today to be able to provide the level of breakdown that's being asked for.
Christine, you mentioned also in passing, and this gets to a question from an audience member about collaboration, cooperation with different parts of the military. Next week's lecture will feature work by the U.S. Army Corps of Engineers, and I think George O'Lee is on the call today. So thank you, George. But could you elaborate a little bit on what were the successes of that, and whether there were points of close collaboration and points where things didn't go as smoothly, perhaps?
So,
you can skip the second part if you want, but that was an answer to the audience question.
So, as the wife of a former Marine, I'm always, I think the military is, such an important role, and they played a key role for us as a system, and the federal support was pivotal for us. I mean, without that, I think we would have been very challenged. Our group didn't have as much direct interface with the military. However, our team members worked closely to support the work that was happening at JAVITS. And then I think one of the things that was a big lessons learned for us, even for our own alternative care sites, is that during these types of pandemics, you also need kind of that clinical leadership, and you need receiving hospitals to help bring surged patients. And the concept of transferring a patient from one place to another where there's room is important, and it was one of the key ways that we were able to ensure that we were able to care for all our patients. And we were able to do it very successfully within our system. However, once we start going outside of our health and hospitals ecosphere, that was a little more challenged in that, you have different ways of operating, and you have different standards, or you had different clinical perspectives. And I think that was one of the challenges, but that we worked through in collaboration with our military partners when it came to transferring patients to JAVITS, et cetera. But then realizing that Javits didn't fill, there was deployed a large number of amazing military clinicians, and so they really deployed inside of our walls, and they really had a tremendous impact to our staff, our clinical leaders, the morale of the team who had been fighting this fight, and we had a lower staff volume that were able to come in and care for patients. And so they played such an important role in being on the front line with us. You know, as I was visiting the hospitals, I would see the Navy here and the Army here and the Air Force. You know, they all came, nurses and doctors, ready to care for patients, and that was just such an uplifting moment, I think, for health and hospitals as a system, to have them alongside of us, helping care for patients. So I'd say that was a tremendous asset that we really truly appreciated.
Thanks. There's another question from an audience member, Beth Greenberg. It asked if you would discuss the applicability or not of prefabricated elements. She mentions head walls in particular, but could you also talk to her question about the use of temporary installations, emergency installations versus things that had been long-standing DOP approved?
Okay, so I think in the case of some of the work, most of the work we did, we didn't find, unfortunately, as many opportunities as we would have liked for prefab. I mean, obviously, I think some of the testing work could have some prefabricated elements to it. And we were really just sourcing whatever we could in the moment. As far as temporary elements, and we even found, you know, there were some products we were trying to use related to, you know, one of the innovative products that we had found had to do with O2 distribution gassing that was looked to be something that we could put in place faster than a traditional oxygen system. And then unfortunately, we had a hard time sourcing it in the moment from our subs were unable to source it. So that doesn't really fully address. We did not stand up temporary prefabricated head walls in the case of our projects. But it's definitely an area that we do want to look at moving forward as opportunities to be more innovative and expedient with our projects.
Yeah, thank you.
Christine, Mildred Tolentino asks, HAC put out an RFP prior to COVID-19 for owners, reps, CM services. Have these RFPs been awarded?
No. So we had about, at the time that COVID hit, we had like approximately 5 to 7 active RFPs for various services, and so not all of them made it through. The evaluation process, and so offhand I'm thinking of 2. One of them being construction management. I think the other one is facade. Those 2 RFPs had to get tabled. Emergency extensions were put in place for existing firms, but those have not been awarded.
Thank you, Christine.
Christine, there are 3 related questions about preparedness, and I'll maybe try to combine them. One from Kyle Keene asked about modeling for future potential unexpected situations. And 2 other questions that are somewhat related talk to the preparedness and responsiveness questions about streamlining the process. James Mills asked, how are you able to streamline specifically the procurement and contracting process over the last few months? And I think Heather O'Neill, who's on the call, also asked, Heather Phillip O'Neill asked if you could talk about different types of procurement mechanisms that might have speeded things up. Paraphrase.
So I think, so we really did, I'm going to go backwards a bit, Rick, if you don't mind. So on the procurement side, when we declared the emergency, that really allowed us to, we had already in-house, we had an emergency contract for a state of emergency. So immediately that emergency contractor was deployed. Unfortunately, COVID is not a normal emergency. This is a marathon of sprinting. And so our emergency contractor definitely, we kept that firm employed as much as possible, but they couldn't do all of the services needed, nor should they. We had a number of on-call, both construction managers, designers, contractors, and so we tried to deploy all of them for specific projects where they were available to do the work. And so by having the emergency declared, we were able to not have every single rule associated with our normal procurement rules be followed, but we were trying to work hard to ensure all our contracts were FEMA compliant because we were reacting to the emergencies that are declared. And we really were also collaborating with a number of agency partners to support us as far as managing even the work that we did accomplish and are continuing to accomplish. And so I think, you know, we streamlined it as well as we could. We do not have a project management system, so we were really just, the team was working 24/7, both with our legal team and our FEMA consultant to kind of ensure that we were looking at all aspects of this, and we were maximizing and leveraging the availability of our private sector partners that were able to really come to the table and help us deliver on a lot of concurrent active work. As far as modeling for the future, that is not an area that I would say our office kind of focuses on. That's more, I would say, focused on around our population health department. And we are looking at kind of what could be our max, you know, we have data around what was our maximum capacity in the first wave. We're taking that analytics and the information of what was deployed where and using that to inform kind of our physical modifications that we may want to make moving forward when we can find the funding, which is kind of a key part of this, is absent a funding source. We are incredibly constrained, and it forces us to prioritize priorities. So as we look to model potential patient volume, we also have to take into account all of our patients that we need to be seeing, both COVID but non-COVID too. And so that is a key feature within the modeling, is recognizing that we have to look at that. As we look at the current hurricane season we're in, we're having to model a potential storm on top of COVID, and that becomes a very challenging, constrained model that we're working through right now.
Thanks. Vinny, I think we have time for one more question.
Okay, so this question comes from Duncan Prawl, and he knows HHC is working towards meeting the city's ambitious GHG reduction goals through energy efficient programs. With added pressure drops of high MERV filters and higher outside air rates, how are these conflicting goals, IAQ and energy, being looked at moving forward by the design and construction teams?
Yeah, so that's a great question. It's exactly spot on. It's one of the things that I can't profess to say we've solved this. We are looking at kind of, as we look at filtration options, we're interested in all, including things that are still being studied, such as electronic filters. And we we have an energy team here, and they were deployed at a number of our sites, helping us both retro commission some of our buildings. You know, we had a lot of agency partners and state partners help us, both EDC, HRO, DDC, DCAS. DCAS has been working at our facilities, and we're trying to keep an eye on all strategies when it comes to funding sources, because hospitals already are challenged with, you know, we're 24/7 facilities that must run. We have federal areas of, you know, air quality guidelines that we have to meet, and we do anticipate evolving code-related requirements in addition to CDC guidelines that have been already shared when it comes to air quality and air controls in our hospitals. So I think that our energy reduction strategies have to be an overlay within that, similar to COVID has become an overlay in how we see our physical space and how we look to plan in the future.
I'd like to conclude by thanking our speaker, Christine Flaherty. Christine, if you turn off your screen share, and Charles, if you would put on the closing title slide. I'd like to thank my colleagues, Charles Shen and Michael Smith from Columbia. And Vinny, thank you as well for excellent questions and keeping the discussion going and everything that you're doing at CMAA.
Thank you, Christine.
I'd like to thank all of our collaborating organizations, ACEC New York, AIA New York, ASCE, I mentioned CMAA New York, New Jersey, the Consortium for Sustainable Urbanization, Engineering News Record, and the National Academy of Construction. Some of our past speakers and past co-moderators are on the call today. Thank you, Marcos Diaz-Gonzalez, Marilisa Stigliano, and Jen Tuckman in particular. And thanks especially to all of you out there in the offices, agencies, and at home throughout New York City and around the world, as far away as Finland, for taking some time to listen in to our lecture today. In the chat room, I mentioned that if you have desire for continuing education credits, please contact us at the CBIPS at columbia.edu website rather than on the chat room. Next Tuesday, we will be fortunate to have two speakers as well as a co-moderator. Our guest speakers will be Lloyd Caldwell and George O. Lee, Jr. of the U.S. Army Corps of Engineers. The co-moderator will be Wayne Crew, the General Secretary of the National Academy of Construction, who's on the call. Thank you, Wayne, along with Professor Feniowski Peñamora of Columbia University as co-moderator and host. And lastly, on our website, https://cbips.engineering.columbia.edu. It's easy to find, just Google CBIPS. You can find information about past lectures, including past PowerPoint presentations and the video recordings of each talk. You could also find information about the upcoming lectures in the program, which will continue into September. Lastly, most recently, we've added to the website in the publication section some thoughts from ourselves and from others about the reopening of workplaces, and particularly open offices. So with that, I would like to thank you all again for joining us today. Stay well, and I hope to see you again. Thank you.
Thank you.
Take care.
Thank you.